Okay. So first question is they are asking about the posterior costophrenic sinus. Okay. So it is so now they are asking at which rib along the scapular line is the recess most safely and effectively accessed. Okay. So they are asking about the tapping. So where do you tap? Okay. So safe tapping is the question. So safe tapping is always at the ninth ICS, which is just above the ninth rib. Okay. Now, in deep inspiration, okay, in deep inspiration, the levels are like this. The lungs versus the pleura. So the lungs are approximately at the 10th rib in the scapular line, whereas pleura is approximately at the 12th rib in deep inspiration. Okay. So in deep inspiration, lung is at the 10th rib, whereas the pleura is the 12th rib. So why do you say it is ninth rib? Because it is below the lung margin and it avoids the if we tap below the lung margin, then it avoids the lung injury. If it is above diaphragm, then it avoids the abdominal organ injury. So you do at the maximum fluid collection space and the safest zone. Okay. So this is the zone for thoracocephalitis. Okay. Okay. So tap at 9, lung is at 10, and 12, pleura is at 12. Okay. Now, let us move on to question number 2. Question number 2. So, they are asking the carpal tunnel has a sparing of thenar sensation. So, they are asking why does this happen? Okay. The sparing of thenar sensation in carpal tunnel is the question. So, in carpal tunnel syndrome, the median nerve is compressed inside the carpal tunnel within the carpal tunnel, which is under the flexor retinaculum. Okay, but what about the palmar cutaneous branch? The palmar cutaneous branch of median nerve has a speciality, of arising proximal to the tunnel or before the tunnel, traveling superficial to the flexor retinaculum, and doesn't pass under the tunnel. Okay. Is that clear? Is that clear? So this property, this characteristic property of our median nerve is what is always this. So this is always a tested area. Okay. This question is always a tested area. Carpal tunnel syndrome. You always know what is median nerve entrapment, what happens, what are the muscles supplied by median nerve. All these questions we discussed, isn't it? Now we are moving one step ahead. What are we asking? They are asking what are the contents of the flexor retinaculum. So let us understand what are the contents of the flexor retinaculum. Okay. Okay. So just a minute. Yeah. So let us see the contents of the flexor retinaculum. Just a minute, okay? Just because. Yeah. Okay. So what are the superficial relations? So the superficial relations are, one is the palmar cutaneous branch of ulnar nerve. Then you have the palmar cutaneous branch of median nerve. Then you have the superficial branch of radial artery. Okay. And indeed you have the ulnar nerve and ulnar artery. And there is one tendon, which is the tendon of palmaris largus. Now, what is significant about the palmar cutaneous branch of ulnar nerve? It supplies the skin on medial half of palm. And what goes under? You have the median nerve. You have the tendons of FTS, FDP. You have the deep slip of flexor retinaculum, flexor carpi ulnaris. I mean flexor carpi radialis. Okay, all these are the deep relations. Okay, so because there is an injury, because the carpal tunnel in carpal tunnel syndrome, the median nerve is compressed beneath the flexor retinaculum. Okay, the sensory loss is only the lateral 3.5, on the palmar side. Okay, and there's thenar muscle loss. The palmar cutaneous branch is spared. Okay, now question number 3. So question number 3 is ASA grading. Okay, so how do you grade the ASA? So grade 1 is normal, healthy patient with normal BMI, who is a non-smoker and an occasional alcohol. Now we have grade 2, which is a mild systemic disease without any functional limitation. And mild to moderately obese smoker, regular alcoholic, well controlled disease with pregnancy. And then you have grade 3 with severe systemic disease. So one point you need to do is one time they are asked something about moderate systemic disease. Okay, this option was given, and kindly remember there is nothing in ASA as moderate systemic disease. Okay, so severe systemic disease with functional limitation and morbidly obese, poorly controlled, alcohol dependent, ESRD. Then you have MICVA, stent more than 3 months, pacemaker, all this. Okay, is that clear? Thank you, Gaurav. Thank you, Zulfin. Others. Vaibhav left or what? Oh, Vaibhav's here. Okay. There is a new joining. Mafat Lal. Hi, bro. Hello, beta. Okay. So here you have LV ejection fraction of 45%. Okay. So it becomes grade 3. Okay. Now, grade 4 and 5, you know, na? Severe systemic disease, life threatening. 5 is moribund. I'll just write down grade 4, grade 5, and grade 6. Grade 4 is severe systemic disease, which is life threatening. This one and all you will be very easily able to identify. That is why I didn't elaborate on this. And 5 is a moribund patient, where survival not more than 24 hours is expected. Sorry. And grade 6 is brain dead. Okay, now question number 4. So, yeah, iron deficiency disorders. What do? You give iodized salt. Okay. So, food fortification, you give iodized salt. Okay. So, under national iodine deficiency disorder control program, that is NIDDCP. Okay. Remember the sign will be a sun, which is laughing. Okay. And here it will be written. Oh, how is Sha written? I think this is like this one. Shanti or Buddhi Ra correction. Okay, Shanti or Bhakti correction. This will be written. Okay. Now, what is the target? What is the sorry, what is the strategy? What are the indicators? These are the three things that you need to know about any national program. Okay. So, target is goiter rate should be less than 5%. What do? You do iodization of salt at the production level and at the consumer level. At the production level, it should be more than 30 ppm, and consumer level it's more than 15 ppm, not 50, 15 ppm. Okay. Indicators are, you have a long-term impact indicator. This one is important. Okay. Then you have a principal impact indicator or epidemiological impact indicator. You have a process or operational impact indicator and the environmental iodine bar dietary deficiency indicator. Okay. Now, what are they? For long-term impact, it is the goiter rate. That is grade 1 and 2. Principal impact indicators, urinary iodine excretion rate. It should be more than or equal to 100 microgram per liter. This is iodine in household salt rate. And environmental iodine or dietary is the neonatal hypothyroidism rate. Is that clear? Yeah. Now moving on to question number 5. So yeah, okay. So bullous skin disease, BP. Okay. What is the collagen? It is BP 190. Okay. Or type 17. Okay. Now DSG 1 is for DSG 1 is for PF. DSG 3 is for PV. Okay. Transglutaminase 2 it is for dermatitis herpetiformis. Okay. What type of bulla? Tense bulla. Negative Mikulski. Okay. That's it. Now, question number 6. Very easy question. All can lead to increased ICP except migraine. Okay. So any SOL can lead to migraine. Now, question number 7. Which of the following provides an accurate description of the norovirus? So, norovirus is a non-enveloped single-stranded RNA virus. Okay. It is a leading cause of acute gastroenteritis outbreaks. Where are in the cruise ship, hostel, hospital, etc. Okay. It has a short-lived immunity. So it can cause recurrent infections. Okay. Okay. So these are the features of norovirus. So that is the physical display. Okay. So whereas Noro come in calcivirus along with HCV, sample, and Noro. Okay. They are non-enveloped RNA single strand. Okay. So viral gastroenteritis is caused by viral gastroenteritis. Okay. It is caused by Rio, most common. And which one? Rota. Then you have calcivirus, which has Noro and Sapo. Then you have adenovirus. Which adenovirus causes diarrhea? D is the fourth letter. So 40, 41. Then you have astrovirus. I remembered it as CAR A. Okay. What is the specialty of rotavirus? It is double stranded RNA virus. It has 11 segments. Okay. Okay. It should be remembered. Okay. That's it. Now, question number 8. So they are asking me, what is the test described here? What is the test described here? What is the test? It is a methylene blue 3 swab test. Okay. So, what is the most common cause of vesicovaginal fistula? Most common cause of fistula itself is urinary fistula is BVF. Vesicovaginal fistula. What is the most common cause of vesicovaginal fistula? If it is a developed country, it is different. If it is a developing country, it is different. In developed country, it is TAH, total abdominal hysterectomy, whereas in developing countries, it is obstructive labor. Okay. The investigation of choices, methylene blue, 3 swab test. And what is the gold standard investigation for VVF? It is the cystoscopy. And vaginal surgery is flat score repair, whereas abdominal surgery is the Chassar Moyer technique or the O'Connell surgery. Okay. So post of instructions. What do you say? No perspeculum, no PV, no intercourse. For how much duration? For 3 to 6 months. Very important. Then no pregnancy for 1 year. Then post of catheter should be in situ for 14 weeks. Okay. If it is identified within 24 hours, you do a immediate repair. If it is more than 24 hours, surgical repair. If it is more than 24 hours, after 6 weeks to 3 months. If the consumption is after PVF repair, deliver by CS. Okay. Now, how do you identify if the upper swab is wet plus unstained? If the middle swab is blue plus wet. If the lower swab is blue plus wet. If the upper swab is wet plus unstained, it is a ureterovaginal fistula. Ureterovaginal fistula. If the middle swab is blue plus wet, it is a vesicovaginal fistula. And if it is a lower, it is a ureterovaginal fistula. Okay. So here it is the upper swab is wet plus unstained. So it is a ureterovaginal fistula. So all about the urinary fistulas in a female has been discussed. Is that clear? Thank you, Gaurav. Yeah. Okay. Now, question number 9. Okay. So now they are asking headlight in the fog appearance. So, what is the most common cause of primary infection? So, it is actually toxoplasmosis. It is toxoplasmosis caused by Toxoplasma gondii. That is given in the question. So, how is the transmission? Transmission is very interesting. The cat passes the oocyst in the stool, and then there is sporozoid in the soil, followed by infection tissue. And there is sporulation of the oocyst, which is the infective form. Okay, then we go on. Okay, it can be muscular toxoplasmosis or ocular toxoplasmosis or neural toxoplasmosis. Muscular will have myalgia. Ocular will have retinitis. Neural will have encephalitis. Okay. We do a peripheral bed smear. We do a peripheral bed smear. And what do you find out? You get tachyzoids that are spindle shaped. Okay. Now, what are the immunological tests? You have Sabin Feldman dye test, which is for IgG detection, and this is the gold standard. Okay. Then you have the IgG ability test. It can be high ability or lower. High ability means it is a chronic infection. Lower ability means it is an acute infection. And now, last but not the least, what is the drug of choice? So, drug of choice is pyrimethamine plus sulfadiazine. Pregnancy it is pyramidine. Okay. Now, one more thing. At last, triad of congenital toxoplasmosis, chorioretinitis, diffuse brain calcifications, and hydrocephalus. This is congenital tox. Children, is this clear? Others? Thank you. Thank you. Now, question number 10. So you have a scaphoid fracture here. So you see a scaphoid fracture here. And yeah. What is the most feared long-term complication of a scaphoid fracture? So what is it? It is avian. We are afraid of avian. Of the proximal pole. Why do you have a proximal pole? Here, because it is a hairpin like tube. That's it. That's why you are afraid of the proximal. Okay, now question number 11. You have a CA maxillary science. Now, which is the earliest feature? Okay. have an on-grens classification where you say there is a line from the root of nose to the ankle of mandible, and if it is above, it is worse prognosis, and if it is below the infrastructure, it is a better prognosis. Okay, that line is called the on-grens line. Okay, and the earliest characteristic symptom is actually blood tinged nasal discharge. Okay, because it is the most common paranasal sinus involved in carcinoma. That is carcinoma maxillary sinus. Okay, early symptom will always be subtle. Okay, now cheek swelling and all, it will indicate a bone's destruction. So always it is a late, and supraclavicular lymph node, it will be a metastasis. Okay, nasal obstruction is a thing that you can think of, but see, maxillary sinus and causing nasal obstruction, so that means it should be big enough. Okay, now question number 12. So they are asking, what is farmer's lung? Okay, so it is due to thermophilic actinomyces. So, thermophilic actinomyces in the moldy head. Okay, so they are asking what is the type of reaction. So you have a classical non-Kashian granuloma with the lymphocytes and all. So most likely type 4 hypersensitivity. Sarcoid, it also shows granulomas, but no clear exposure trigger will be present. Type 1 will be IgE mediated, whereas type 4, it is late or delayed type. Okay, T lymphocytes. UIP, it is a fibrosing disease without any granulomas. Okay, so is the bird fanciers lung. Okay, it has also the same mechanism. Okay, just to brush up, type 1, type 2, type 3, type 4. So type 1 will be allergic. Here it will be cytotoxic. This immune complex mediated. Whereas here it is delayed type. It is associated with allergy, RBC, antigen antibody complex. Here it will be intracellular antigen. Okay. Examples will be allergic rhinitis, bronchitis, dermatitis, ABPA, then anaphylaxis, etc. Type 2, which is blood transfusion reactions, and autoimmune hemolytic anemia. Type 3 will be AGN and PSGN, RA, Arthur's reaction, serum sickness, and the important thing is type 2 lepra reactions. Okay, here it will be tuberculin test, Manto, lepromin, type 1 lepra reaction. Okay, is that clear? Thank you. Now, question number 13. So, 2-year-old boy presented with a choking and coughing while eating peanuts. Okay. So, there is hyperinflation on one side. So, there is hyperinflation on one side. Okay, so there is hyperinflation of the right side with a mediastinal shift to the left on expiratory view. So it is the classical ball valve obstruction. What does it mean? It means air enters but can't exit. Okay, so what will be the next next step? It is rigid bronchoscopy. Why rigid bronchoscopy? Because it can be used for diagnosis as well as removal. Okay, it is preferred in children because it has better airway control and larger lumen for instruments. Why is it not flexible? It is not flexible is not ideal for removal in children. And direct laryngoscopy is for upper airway and not the bronchial tree. Okay, that's question number 14. Okay, now they are asking the management of a severe theophylline toxicity. Okay, so what to do? You should give multiple dose activated charcoal, control the seizures with them benzodiazepines, and prepare for urgent HT. Okay. Naloxone glucagon should have been given for opioid or beta blocker toxicity. Insulin dextrose for beta blocker or calcium channel blocker overdose. Calcium gluconate bicarbonate should have been given for hyperkalemia or TCA toxicity. This for beta blocker or CCB toxicity. This for opioid. Beta blocker. Okay, now question number 15. So they are asking in a road photoreceptor cell, what is meant by dark current? So dark current is actually what happens in the absence of light. So when there is no light, okay, when there is no light, CGMP levels will be high. Okay, so the CGMP gated sodium channel open. They remain open, and there will be continuous sodium and calcium influx. Okay, So thus there will be continuous depolarized level of the rod photoreceptor cell, and there is continuous glutamate release. Okay, but when there is a light, CGMP decreases, the sodium channel flows, and cell hyperpolarizes. Okay, there will be decreased. So in dark, in light. So in dark, it is depolarized, and in light, it is hyperpolarized. Now, question number 16. A child is diagnosed with PKU, the implementation of a long-term dietary. So that is to prevent the complications. So prevent complications, the level of prevention will be tertiary prevention. Levels of prevention has already been discussed once. Now, morbid jealousy and use of Wittmann formula is for alcohol. Okay. What is Wittmann formula? The blood alcohol concentration is given by the expression alcohol consumed divided by the body weight into R, where R is the distribution factor, which is 0.7 in males and 0.6 in females. Okay. Other syndrome related to alcohol is Othello syndrome. Okay. That's it. Now, question number 18. So they give a history of age more than 60 with progressive exertional dyspnea, dry cough, and bilateral end inspiratory crepitations. Basal end inspiratory crepitations. This one. Okay. And there is decreased BLCM. Okay. So this is actually the Velcro crepitations. Okay. And there is a restrictive PFT. Okay. So what do you see here? You see a basal subpleural predominance with honeycombing and traction bronchitis. Okay, reticular obeliscus. This is characteristic of UIP. Okay, so old age, clubbing, all this means UIP, whereas this one will be young age. Okay, and there will be ground glass appearance in NCP. Okay, so UIP is most common in every all other rheumatological diseases except RA, where most common ILD in RA is NSIP. Okay, so always remember most common ILD in rheumatoid arthritis is not UIP, it is NSIP. Okay, so kindly remember this point. Okay, now question number 19. So on non-contrast CT, they are telling it is approximately 950 Hounsfield units. Okay? 950 HU is what is given. So that means it is a very high calcium containing stone. Okay. And it doesn't dissolve with urinary alkalinization. Okay. It is calcium oxalate stone. Okay. And uric acid stones are usually low density. Okay. That is around 200 to 400 HU. Cystine stones are moderate density. Struvite, there will be infection related. Okay. So if it is a low HU, it is uric acid, high HU is calcium. Okay. Now, last question, question number 20. So they're asking the what is the initial peak inspiratory flow rate? Okay. The peak inspiratory flow rate setting for a VCV mode, volume control ventilation. Okay. In a standard adult ventilation, always set the TV at 6 to 8 and flow rate at around 60 to 100. Okay. Flow rate should be set at around 60 to 100. Okay. Is that clear? Okay. Now, what is the ventilator setting in ARDS? Can somebody tell me what is the ventilator setting in ARDS? I think in ventilator, the only thing they ask now is the ARDS ventilator setting. Low TV. Yes. So in a yeah, less speed. No, it's not less speed. So in ARDS, okay. Firstly, initiate volume or pressure limited ventilation. Okay. How much? So it will be low TV. That is less than or equal to 6 ml per kg. Then plateau pressure of less than or equal to 30 centimeters of water. And RR less than or equal to 35 beats per minute. Okay. So the next thing is then you oxygenate. Okay. Okay. Then you minimize the acidosis. So when you oxygenate, it should be FiO2 less than or equal to 0.6 and SpO2 should be maintained in 88 to 95%. Okay. So always remember in ARDS, it should be low TV, high. Okay. Because PEEP will prevent the collapse, increase the recruitment, and reduce the work of breath. Okay, that's it, guys. Hope that was useful. Done. Okay, dears. Thank you. Good night.